Good afternoon. Welcome back to UCSF Medicine Grand Rounds. I'm Bob Wachter, chair of the UCSF Department of Medicine. Welcome to our live audience from our department, to our colleagues from around UCSF and throughout our health network. And as usual, we'll post this video to at about 7:30 tonight on YouTube. I'll tweet out a notice of that and the web address. And our previous Grand Rounds are now, I think, over 1.5 million views. A few quick ground rules for the audience are shown here. If you'll be on mute, if you have a question, please type it in the Q&A box. We'll monitor them and try to ask as many as we can. And we've added a closed captioning option by popular demand. And so to do that, there's a closed caption button at the bottom. And if you click on that and go to show subtitles, that should do it. So we've entered what feels like a new phase of the pandemic. We are in the middle of a very large surge, although there are some mild signs of improvement, particularly here in California. Not enough, though, and still many people are dying nationally. We're still having about a 9/11 worth of deaths every day. Vaccines are here, but the distribution has been rocky at best, with complaints about the speed and fairness. UCSF has done overall quite well in its vaccination program, and you'll hear more about that in a few minutes, but it is a real challenge to get it right in every dimension, operationally and ethically. The vaccine issue is really one of the more interesting issues in that for now, we have massive demand, not enough supply, and at some point in the next several months, that will toggle to a different kind of problem where we need to make sure people take their vaccines, and we'll have the issue of vaccine hesitancy to deal with. So it has many different dimensions to it. And finally, now hanging over all of this is a change in the threat. We thought we were running a race against a virus that we didn't know a year ago, but we'd come to understand and mostly hate over the past year, and it now seems to have morphed into a few different versions of itself, some of which are better at some of the things that it does, including infectivity and maybe even evading the vaccine to some extent. So the stakes have been raised, and the need for speed has grown even more in the last couple of months. And of course, all of this, we won't talk about it today, comes against the backdrop of the horrifying events we saw in Washington last week and are still seeing, and a new administration that will take over in 140 hours and 57 minutes, not that I'm counting. So today, with all of that as background, we'll focus on vaccines and variants. For vaccines, we'll do two parts. One is an update on how we're doing here at UCSF from the leaders of our vaccine team, Desi Kodis, who is UCSF's Chief Pharmacy Executive, and Susan Smith, who is our Chief Faculty Practice Officer. Susan and Desi and Gina Antinarelli and several of their colleagues have been leading our vaccine response. And I have to say, and before we start, doing a magnificent job of it. I'm sure they feel like they're the complaint department, but I think we've mostly gotten it right, and we'll talk about that. We'll then broaden the vaccine conversation, and I'm thrilled that we have Paul Offit making a return appearance with us. I won't go into his bio in great detail, but Paul is one of the foremost experts on vaccines in the world. He's the professor of vaccinology at Children's Hospital of Philadelphia, a professor at Penn, where he runs the Vaccine Education Center. And Paul's been a member of every key advisory committee on vaccines in the universe, including the one that advised the FDA on what to do about the Pfizer and Moderna vaccines. And he's going to talk us through where we are in the world of vaccines. So Paul, welcome back. Thank you for being here. And so that part of the discussion where we're talking about vaccines will take us to about 12:50, and then we'll switch gears to spend the last 25 minutes talking about the new variants, what they are, what they do, and whether they're a distant threat that's over the horizon or something that represents a clear and present danger to us. And I'm pleased that we have one of the world's experts on viral diagnostics to help us with that. That's Charles Chu, who's a professor here in our Department of Laboratory Medicine and our own Department of Medicine in our ID division. Charles is also director of the UCSF Abbott Viral Diagnostics and Discovery Center and associate director of our clinical microbiology laboratory. And so he will educate us on what these variants mean and we should think about this and what kind of they represent. So that will go till about 1:15. So that's the intro. Let's go ahead and get started. beginning with a review of where we are on the vaccine situation here at UCSF. And so let me bring on Susan and Desi.
So thanks very much, Bob, for the introduction and inviting us back to give you an update. Let's go to the next. So first, I just am going to show you how many vaccines we have delivered. So we've delivered just over 20,000 vaccines as of early this morning. Reminder that we began vaccinating about 4 hours after our vaccine arrived on December 16th. Went through the holidays. Dose 2 began on the 6th of January for us. And you can see the distribution. We're still mostly on first doses, but starting to pick up on the second doses. Next slide. Drilling down a little bit more, this is our phase 1A. It's part of our dashboard. It's a little bit more complicated dashboard, but just thought I'd call out where we are in total for phase 1A. So our population of phase 1A is just over 23,000. As you can see, of those, about 91% or 21,000 are active on MyChart. And of those, we've offered the vaccine to about 99%. We're pretty close. This represents both our West and East Bay operations. And of those, 82% have consented and said, yep, I want the vaccine. 79% have scheduled, and 77% of the total of phase 1A has actually received the first dose. You can see the second dose numbers there. And the two circles there are to point out our gaps that we're working actively to resolve. So there are a couple thousand people who have not actually activated MyChart. And of those, there's, sorry. Can you hear me okay still? I'm sorry, there's a buzzing noise up above.
Just keep talking. I think people are used to Zoom kinds of things, so it's fine.
I actually went up and told them not to buzz doing this, but that's okay. Okay, so they have not activated MyChart, so there may be technical problems, language problems, or other reasons why people have not activated. And then of the people who have activated, there's still people who have not consented. And again, not sure whether those are technical problems or language barriers or vaccine hesitancy. So we have teams working on mitigation strategies for those. We have held some special sessions to help get those people in who don't live on the web, don't necessarily have active email addresses, have language issues, and we're beginning to work on what are the root causes for the vaccine hesitancy to the extent that they exist. Next slide is for Desi.
Thanks, Susan. So good afternoon, everybody. Here's another way to look at our vaccine. And again, this was from a little earlier in the week when we had, just over 18,000 people vaccinated. And this is really to look at our just-in-time inventory. Bob talked about this as well. The vaccine is not coming by any way, shape, or form through traditional supply chain for drugs. So wanted to show you, and you could see the various points where we're at. But the bottom line is that all of our first doses, almost 85% of them, have been administered or are reserved for appointments next day. 100% of our second doses have either been administered or are reserved for appointments. So that's really the gist of all of this. Also gives us our run rate to let us know, and this was before we had a delivery in this week, that we would be at our run rates out of vaccine within a couple days. So that's on the 18th or Monday. Susan? Next slide, please.
Next slide. Okay, so you can see we're sort of running just in time on vaccine, but we're trying to make sure as much as we can that those from phase 1A have been offered a real opportunity to schedule while we're still in phase 1A. But we are quickly moving towards phase 1B. We're carefully following the CDPH guidelines that are aligned with the CDC guidelines. And they, a week or so ago, broke phase 1B into tier 1 and tier 2. It's changed again since this was published, and their website isn't yet updated, but last week they were starting with individuals 75 and older, and then they've broken the essential workers into various groups. The second tier of 1B is individuals 65 to 74. We probably will start with 75-year-olds just to get our feet wet with making sure we can get elderly patients through our vaccine process without problems, and then we'll be opening it more broadly to the 65 and older. It's not until phase 1C that underlying health conditions weigh in on the priority for vaccination, at least at this point. With that, I think that's all we were going to cover on slides, Bob, so back to you.
That is perfect. Thank you. Thank you both so much. So there are a lot of questions that have come in. I'd say a lot of them are would go into the category of how exactly is this going to work as we begin rolling it out to these other groups. It's been challenging enough to do kind of our own people, and they're in our HR system, but now we're rolling it out to patients. So if I'm a UCSF patient, how am I going to find out that it's my turn, and how are you deciding on the allocation order among patients and between patients and other folks that we're also offering vaccine to?
Yeah, great question. And honestly, we're learning and adjusting things pretty much on a daily, sometimes hourly basis to make sure that we can manage this. So there's sort of two interesting things to think about. We've also been asked by the city of San Francisco to help vaccinate healthcare workers in San Francisco who don't have, who are not working for UCSF, Kaiser, one of the big organizations. So those people, if and when we can get that figured out, will not be patients or employees. So they represent yet another challenge. What we're going to try to move towards is an ability to do scheduling from the web. We've been very much relying on MyChart, and MyChart has some limitations. The first set of invitations that we send to our patients will probably still be on MyChart, but we're working on a more open access to the appointments that will be based on our staff and our patients and any healthcare workers attesting that they in fact belong in the group that we are then vaccinating, and then being allowed to schedule. So we're going to rely on the honor system and hope that people will really respect that and not take advantage of it.
And so if I'm a 76-year-old person who's been seen in the neurology clinic at UCSF, do I just go to can I expect that I'm going to get an email sometime in the next blank number of days or weeks? Is that how it's going to work?
Yeah, we will notify. We've sent out one blast patient message telling them that we're about to start this process. And when we get the details of how to have people schedule on their own and sort themselves into the appropriate group, we will send out emails to let people know exactly how to do that. We still, again, don't have the details of that exactly ironed out, so I can't show you a screenshot on how that happens, but we will be able to do that shortly.
Okay. As you talked about the predictability of supply, and that this comes unlike anything else that's ever come to us. So as you're doing your planning, I mean, you have this now, all right, all clinicians and people in their offices in San Francisco are part of the eligible pool, and maybe 75-year-olds and up, but maybe 65-year-olds. In doing that, there's this other factor of we're going to have 5,000 doses or 12,000 doses. Like, when do you find that out? Is it like when the truck pulls up to the loading dock, or you have a day or two notice?
So we usually get a notice almost a week in advance that there's going to be a shipment. So actually, just before this call, I found out that we'll be getting a shipment on Tuesday. So again, it's what is said that we're going to receive from either the San Francisco Department of Public Health or through our multi-county entity and University of California in total. And usually, we've been doing this a little over a month. I think it's 5 going on 6 weeks. We do get what we are told we're going to get, but there are times where we have not received what we're told. So again, this is a just-in-time, day-to-day sort of piece that, Susan, Gina, and I have been working through. So I'm in contact on a daily basis with Department of Public Health and those that are allocating inventory, and also letting them know that the supply is not sitting in a freezer somewhere. It is almost just in time when you have less than 15% of your supply for 48-hour appointments from now.
Yeah. So we're going to need to move on in a second. I have a couple of quick final questions for you, but just to highlight a number that may have sort of flown by people, that we have given out and injected 84% of our supply. The national average is 30, California's average is 25. So we're doing amazingly well in terms of sort of getting it from the freezer to people's arms really, really quickly. Vaccine hesitancy, I think, Susan, you mentioned that we're not sure why that 20-ish% of people are not signing up. Do you have a sense of, are there people who just do not want to get vaccinated? And what are the things you're hearing about that?
I would say we haven't heard a large number of people saying, I don't want to get vaccinated. So we've started the focus on the technical problems, and those have been significant. Just getting people over the digital barrier can be a big problem. But we also know that there are some differences in signups between in the race and ethnicity data. And so we're going to take a deeper dive in conjunction with some of our diversity, equity, inclusion people at UCSF to understand that better and see if there's mitigations that we can help with.
Great. Maybe last one, and there are a ton of questions in the Q&A. We're just not going to get to them. You guys keep doing town halls all the time, and we'll get you the questions as well, in case there are some that you want to answer offline. Desi, everybody was worried about side effects and all that. So now we've given out 20,000 vaccines. I had my first shot and my arm ached a tiny bit the next day, but it was a big nothing burger, I thought. But that's because I'm too old to have an immune response. Can you tell us what the experience has been so far in terms of what people's side effects have been? And have we seen any of these allergic reactions we've heard about?
We've been tracking, and actually Susan did present that data that we've seen from UCSF, and we have not had to administer an epinephrine shot. We have given diphenhydramine or Benadryl a couple of times. We've seen some dizziness. There are people that are very emotional about receiving the vaccine. There's this sigh of relief. I mean, walking through the clinics and seeing people's reactions, people are so grateful and so thankful, and the hope is there. So we have basically observed people for longer than the recommended amount of time, but seen some reactions, nothing really intense thus far.
Great. Susan, anything to add?
I would say that the second dose people, I've heard anecdotally, are having a lot more myalgias, fever, the kinds of things that that are expected from the vaccine as well, but maybe not so comfortable.
Great. Well, we go on forever, but I really appreciate the update. And again, I think I speak for everybody here. We're grateful to you and your teams for doing this work. It is really hard. It's a lot of emotion associated with it, but really important that we got it right. And I think the evidence is very clear that we have. So thank you. I'm sure we'll have you back on in a few weeks to see where we are then, but really appreciate it. Let's bring on Paul. There he is. So Paul, before you start, I'd just love you to react to what you heard. I'm sure you're seeing an experience in Penn about how it's rolling out. What are your thoughts from what you've heard about what's happening here?
Yeah, at Children's Hospital Philadelphia, we're pretty good about vaccinating. We have several sites. You sign up, they vaccinate about 12 people every 30 minutes. It's very well organized. You're not waiting more than a few minutes, and you have a place to wait for 15 or 30 minutes, depending on your previous history with anaphylaxis. And we do about 2,500 people a week, roughly. So we're getting there. We have about 15,000 employees. at our hospital. But, it's a little easier for us. I mean, we're a children's hospital. So although we certainly see cases of COVID, we're not overwhelmed by it by any means.
Yeah.
We're a hospital, so we're used to giving vaccines. The nurses are used to giving vaccines. So, if it doesn't work well in a place like Children's Hospital Philadelphia, it's never going to work well.
Well, I have to say that, part of my sort of engagement on this issue was seeing the challenges that many of our other academic, sites, certainly Stanford had problems, MGH had problems. There was a big report in the New York Times about challenges. And it was sort of like if big academic health systems that have HR systems and computer systems and mostly, clinicians, if they can't get it right, how is this going to work when we go to 300 million other people? So it was almost an early warning signal that this is harder than it looks. So let's let you, I think you're going to make some sort of introductory comments on kind of what you've been seeing and over the last couple of weeks. Why don't you go ahead and do that, and then we'll go and do a discussion after that.
I mean,
All right.
certainly things right now are pretty grim. I mean, we're over 4,000 deaths a day. I think we have more deaths yesterday than South Korea has had during this entire pandemic. And I think also more than Japan has had in this entire pandemic, which shows you how bad we are at this. And I think it's going to continue to be grim as long as the weather's cool, as long as people still aren't very good about masking and social distancing. And the vaccine is just rolling out. But I'm going to make the following optimistic statements, remembering that I'm a Philadelphia Eagles season ticket holder, so my optimism should be, rated on that. But you have two vaccines that are now getting out there that are 95% effective against disease. That's remarkable. And at least 95% against severe disease, and in people over 65, and in people with a variety of comorbidities. I think a year ago, when we first isolated this virus and sequenced it in January of 2020, I don't think there's a scientist on the face of this planet who would have thought that these two mRNA vaccines would have been subjected to large phase 3 trials, found to be this effective and getting out there. So that's good. I think there are the other two vaccines that are around the corner, AstraZeneca's vaccine and Johnson & Johnson's vaccine. I'm on the FDA's vaccine advisory committee. So I think we're not going to be hearing about them in the month of January, I'm pretty sure. Likely would be hearing about at least one of them in the month of February, with a goal, hopefully, to getting those vaccines out in March. You have two other vaccines, the Novartis vaccine and the Sanofi GSK vaccines, which are purified protein vaccines, that hopefully will be coming online by April as those trials finish out. So more help is on the way. That's good. There will get warmer, and this is an envelope virus that's spread by small droplets. Usually when the weather gets more humid, those small droplets will acquire water and tend to drop more quickly. So usually these kinds of viruses are less transmissible in the summer months when it gets hot and humid. So that's good. You have an administration that has a clue. It's actually interested in trying to stop this pandemic instead of asking you to engage in some cult of denialism. So that's good. And I think that the other thing is that we don't talk about this much because it's so horrible. The price that was paid for this was so horrible, but in terms of deaths and suffering and hospitalizations. But the report is that about 23 million people have been infected in the United States. Well, that's people who've been tested and found to be infected. I mean, there are a lot of people who had mild disease or asymptomatic disease who just never got tested. So it's only with antibody surveillance data that you can really get a sense of how many people have been infected. And there were studies in November and then more recent studies showing that that number is probably off by a factor of 3 to 4. So assume three times 23 million. Now you're in this sort of 65 to 70 million people who have already been infected in this country, who, when they were exposed to this virus, are very unlikely, I think, to get certainly sick, or certainly significantly sick. So that's a base of about 20% of the US population that's already at some level vaccinated, I mean, for all practical purposes. And you have, if you use there's a book called Plotkin's Vaccines, there's a chapter in it called Community Immunity by Paul Fine. There's actually a formula to answer the question, what percentage of the population needs to be vaccinated in order to stop spread, in order to get the R naught to less than 1. And that formula is R naught minus 1 over R naught divided by the vaccine efficacy. So let's assume, just for the purpose of this discussion, that the R naught, the contagiousness index, is 2. 2 minus 1 over 2 is 0.5, divided by an efficacy of 0.95, 95%, then that gets you to 0.55, or said another way, that you need to have 55% of the population immunized in order to stop spread, knowing that you've already gotten a certain percentage of people who are already protected. So with all that, I think that if we can vaccinate 1 to 1.5 million people a day. And certainly that's the Biden goal. We're already vaccinating about 500,000 a day. So I don't think it's a leap to believe we can get there. What we're trying to do that's so hard is we're trying to create a public health infrastructure that doesn't currently exist, which is to say an infrastructure for mass vaccination. But you're starting to see it. I mean, Pennsylvania Convention Center now is a site, Dodger Stadium, I think, is a site, and that's what you want to see, mass vaccination. And I think we will get there. And so I'm going to predict that as sort of February turns to March, we're going to start to see things improve. And I think that if we can continue at a high immunization rate, in the sort of 1 to 1.5 million, we will start to see, I think, a gradual diminution with, I think, us being in pretty good shape by June. So that is my prediction. But then again, I think the Eagles are going to win the Super Bowl every year. So you need to know that. But
A big grain of salt when listening to you. Well, first of all, I rarely criticize you, but I will. That I think before you give people that much math, there needs to be a trigger warning. So you just launch right in. Formula. Let's spend a minute on the formula. Are you saying that we reach herd immunity at a lower number, or are you saying the curve starts bending in a meaningful way when we get to half the people being immune, let's say?
I think we reach herd immunity at around 60%. I'm going to predict that we will reach herd immunity. So see, what the one thing it's not that I didn't explain was when you say 95% efficacy, what I'm talking about in published efficacy is efficacy against disease. What you really care about is efficacy against contagiousness. I mean, efficacy against transmission. That's what you care about. We don't know to what extent these vaccines are protective against asymptomatic infection where you could have significant shedding. But I really do believe when we do those studies, we're going to find, although you may be asymptomatically infected, that you will shed less virus if you're immune. If you've been vaccinated than if you haven't. I mean, I was fortunate enough to be part of a team at Children's Hospital that created the strains became the rotavirus vaccine, Rototec, and that vaccine doesn't protect against asymptomatic infection. Nonetheless, we have virtually eliminated that virus from the United States. So I think that we, although we make a big deal about this asymptomatic shedding, I predict that we will shed less virus, which is really the critical issue. So.
And people talk about the Moderna study where they actually did some testing of that, and it was sort of hopeful in terms of answering that question. Is that, do you feel like we sort of partly know the answer, but we're being reluctant to sort of say it out loud?
I think you can't look at shedding because usually we look at genome. We don't usually look at infectious virus. And the real way to answer that question is contact tracing. That's the way to answer the question about contagiousness. And then you can go back and look to see what extent, shedding of genome, at what cycle time, you can then say, okay, here's the correlate. But you really have to do contact tracing to answer the real question about shedding. And that hasn't been done.
Okay. In terms of we'll stick with the math for a second, because I guess that's where you got my head there, and we'll get out of it soon. If we only need to get to 60%, I guess you're implying that number is not just the number of people vaccinated, it's the number of people vaccinated plus other people who had prior infection, assuming that infection yields an immunity that is still good enough.
And remember, we are vaccinating people who've been infected. So
exactly. You just can't add those pools together because we're starting on vaccinations with at least some of the people already were infected. So you sort of have to subtract them out a little bit as you try.
Because only 20% of the people you're going to vaccinate have already been infected.
Yeah,
roughly, I think somewhere.
Got it. But when you say herd immunity 60%, that's like the most hopeful number I've heard for a whole long time. And Fauci was saying 70% and then said, actually, it's really more 80 or 85. So where is the difference? It would seem to me this is a knowable number. So why is there, we're talking about tens of millions of people different in terms and months different when we will reach the right place. Why is there sort of dispute on that number?
So I'm going to say, because I'm taking that 95% number literally as protecting against not only disease, but contagiousness. And I'm also saying that I think that the 20% of people who are essentially been naturally infected are immune. So and understanding that we're going to if you take the 55% number, remember, so whatever 20% of 55% is around 10%. So that sort of gets knocked out. So then now I'll put it up to maybe 65%. That's what gets me to that number. But we'll see. We'll see how this plays out. But I choose to be optimistic on this. I really do think we can get.
We all love to choose to be optimistic. So let's talk about. You were sort of remarkably ungrumpy about the rollout. It sounds like you feel like it was predictable. This is hard. We don't have a public health infrastructure. We'll figure it out. Learning curve. Is that right? When you heard in November that we had two vaccines that were 95% effective and safe, Did you think that, and it felt like, and the bottleneck might just be supply. We're just not going to have enough doses rolling out. Did you imagine that we might be in a situation where, we thought we'd have injected 25 million people by now and we've done 10 or 12 million, or was that predictable?
Well, I mean, it was certainly predictable in the sense that we don't have a mass immunization public health system. So that was predictable. I think that in retrospect, maybe I should have sounded grumpier, but I think that when we were essentially mass producing this vaccine at risk, I mean, the government was willing basically to put $24 billion into this effort, according to the Foundation for Vaccine Research. That's an amazing amount of money, and they got their money's worth. The government paid for phase 3 trials, with the exception of Pfizer's trial. The government paid to mass produce these vaccines at risk, not knowing whether it was safe, not knowing whether it was effective. Obviously, companies aren't going to do that. They're going to wait till they do the phase 3 trials and show that something works before they mass produce. So we did that at risk. At the same time we were doing that, we should have also put an infrastructure in at risk, not knowing whether these vaccines were going to work. And we didn't do that. I think we just thought, great. And I think at some level, it's a little bit of a clash of cultures between the Department of Defense and the CDC. You hear a lot from General Perna, who's, the Department of Defense guy, and their culture is a lot different. I mean, he talks a lot about making sure that these supplies aren't attacked, that from some nefarious foreign agent. I would much rather have Ann Schuchat talk to me every day about how they're going to be distributing and administering. I think we can mass produce this. That doesn't worry me so much. What worries me is the distribution, administration, that you distribute it in the right place, in the right way, and that we administer it in the right place, the right way. I'm on this, Rachel Levine's our Secretary of Health. I'm on this committee that helps advise her, but she wants to set up immunization clinics in the central part of the state where we have, with kind of retail pharmacy free zones that she feels she needs that. She needs personnel, she needs money. And she's trying to talk to the federal government about what she needs, how she needs it. And that's been very frustrating for her. So that's at least a big part of the problem.
They really didn't appreciate the complexity of the last mile problem here. And they thought if they could get it to a freezer in your state, they were good, and they didn't understand that until it's injected, it's not good.
Right. Philly, we're Philly in the east, Pittsburgh in the west, and Alabama in the middle for the most part. But it's the Philly and Pittsburgh are easy. It's going to be the center part of the states that are harder.
So tell us what, when we began learning about these, obviously you've understood this and been in the middle of it for much longer than that, but most of the rest of us lay people kind of first heard about these vaccines 2 months ago. And we heard about 95% effective, and we heard about safety profiles and freezers and all that kind of stuff. What have you learned in the last 2 months and maybe in the last month about these vaccines that has changed your thinking about them? Have we learned anything more about safety, the short-term safety, the long-term safety?
Well, so anaphylaxis is an issue at roughly 11 cases per million doses distributed. Which is frightening to watch. But on the bright side, it is immediately evident there is a treatment for it, and we know to watch for it. So that's good. In the trials, there were 7 cases of Bell's palsy among the 37,000 people that were vaccinated with Pfizer and Moderna's vaccine. There was 1 case in the placebo group among the 37,000 people. That 1 case in the placebo group was roughly the background rate of what you would expect. So the 7 cases was higher. So I've been really curious to see what happens as this rolls out. I mean, we're approaching about 10 million doses now, and I haven't heard that story, the Bell's palsy story. I think we need to give it a couple months to see, but I feel encouraged that may have been a coincidental and not causal association. It's always the tyranny of small numbers generated from large databases. I mean, you see this all the time. Like the HEPLISAV-B vaccine, for example, the third of the hepatitis B vaccines. I mean, there was all based on small numbers, a statistically significant increase in myocardial infarction in the vaccine group. But there was also a statistically significant decrease in prostate cancer. So, I mean, both of those things I think were wrong. And you sort of see this all our vaccine, the rotavirus vaccine, 70,000 person trial. There were 5 cases of arm and leg fractures in the placebo group and none in the vaccine group. Therefore, we made a vaccine that prevented arm and leg fractures.
Fantastic.
The FDA didn't give us an indication for that, but that's what we found.
Yeah. So, and you mentioned when we spoke to you maybe a month and a half ago that when people worried about the safety and how fast these trials were, and okay, maybe we didn't see anything nasty after 2 months, but what about 6 months? And I'm going to wait. You made the point that in the history of vaccines that you knew of, there was essentially nothing that emerged later after 2 months. You still feel that way, that that if something has not shown itself by now, like if you say, I want to wait 6 months to be sure this vaccine's okay, that's sort of not an evidence-based thing to do.
I mean, yes, that's what I mean. Just polio from the polio vaccine, visceral tropic disease from the yellow fever vaccine, Guillain-Barré syndrome from the influenza vaccine, narcolepsy from squalene adjuvant flu vaccine used in Europe. I mean, those can cause sort of long-term problems, but they do occur within 6 weeks of a dose. I actually had a conversation with someone at the CDC where we sat down and tried to think of a side effect that wasn't detected in that first 6 weeks and couldn't find it. So when people are worried, the safety issues, I mean, we looked 2 months after this last dose for those 2 big trials. Those trials were the size of any pediatric vaccine trial. I mean, HPV vaccine was a 30,000 person trial, conjugate pneumococcal vaccine, 35,000. So this was the same size. I mean, the only difference really was efficacy. You only knew that this was effective for 3 or 4 months. That's all you knew. But, when you have such a high level of efficacy and you can see evidence for T-cell immunity, suggesting it's going to be longer lived immunity, I think you can feel pretty comfortable you're taking at least leap in, that you're not taking an unnecessary leap, and you're not going to do a 2 or 3 or 4 year trial to see how long it's effective when almost 400,000 people have died this year.
Yeah. So let's talk about some of the strategies that people have proposed. I've been one of those people for kind of moving things along, and whether you think these are worth considering or silly ideas. One is delaying the second dose, and that has kind of 2 flavors. One is sort of to strategically delay the second dose, and the other is what at least both this and the next administration have said they're going to do, which is no longer reserve the second dose to kind of free it up and sort of taking the risk that some people might be a little bit late in getting it. So what do you think about that? What do you think about the risk of delay?
Okay.
Go for it.
I have weighed in on this on the PBS NewsHour on Friday. I read what you and Dr. Jha wrote in the Washington Post and have a problem with it. So here's my problem.
Please go.
We know that as at 2 doses that this vaccine is highly effective at preventing disease. We do have some data between dose 1 and 2 for the Pfizer vaccine, some data between dose 1 and 2 for the Moderna vaccine, where the Pfizer is about 52%, the Moderna, depending on how you slice it, 80 to 90%. But we only know that for a few weeks. We also know that you have a lesser immune response after dose 1 than dose 2. We clearly know you get a booster response with dose 2. We also know that you get a more detectable T-cell response after dose 2 as compared to dose 1, suggesting longer lived immunity. I don't have a problem with getting all the vaccine out there. I think vaccinate as many people as you can, but you have to get that second dose in. And I think what worried me in this, not so much that instead of getting it 3 weeks later, you get it 4 weeks later, 5 weeks later. That doesn't bother me so much. I don't think that vaccines are based on like the lunar month. I don't think a week or 2 makes a difference. But I do think that if you send the message out there that people, because people have told me this, look, it's, I read that it's 80 or 90% effective after dose 1. Why get the second dose? And see, that would be bad. And when I said that on the PBS NewsHour, I got a call the next day from someone in the Biden transition team saying, this is not our plan. This is a 2-dose vaccine. We are not trying to delay the second dose. You're going to get that second dose in 3 or 4 weeks. We just think we can get the vaccine out there to give that second dose. And then 2 people from the Biden transition team, Mike Osterholm and Celine Gounder, were on CNN that next day saying, not our plan. It's a 2-dose vaccine. So I think they had a messaging problem when they were saying, we're getting all this vaccine out there, get the second dose when you can, because the first dose still works. And that's not it. Not just me. I mean, the FDA made a statement. Dr. Fauci made a statement. So I don't think when you and Dr. Jha wrote that, that's what you were saying. I don't think you were saying don't get a second dose.
I mean, we were trying to generate this discussion and actually trying to sort of move things along in some way. And I kind of felt that the idea of no longer being so prescriptive about we're just holding half of the doses in a freezer somewhere and not even releasing them just felt like it was sort of it was more harmful than helpful. You have to get more people to get their first dose fast. But it sounds like you think that a strategy of delaying the second dose is a bad idea. That
yes.
People
I don't think that's the strategy.
Yeah, that makes sense.
Strategy, according to at least what I talked to. Actually, I talked to David Kessler, but who's great. I mean, I'm so glad he's involved with the Biden team. They believe that by getting this vaccine out there, that they can mass produce what they need to and get out that second dose. They don't think they needed to hold the second dose because they believe they can meet that need. Great. I'm all for it.
Okay. Other things that have been proposed, sort of mixing and matching, the second dose being a different dose than the first dose, in terms of bad idea.
Yeah, don't make this stuff up. I mean, this is why you do phase 1 trials. You do phase 1 trials to figure out the right dose, to figure out the right dosing interval, and then you move forward phase 2 and phase 3. You don't sort of tinker around at phase 3 to see what looks good. I just, very unnerving. I think the UK people did that with sort of half dose, full dose, 1 month, 3 months, and that's just not the way to do this. And so do the phase 3 trials the way they're supposed to be done, generate the data that's solid, and then follow the science.
What do you, in terms of the prioritization scheme? So we had lots of plans and group 1A and 1A sub whatever and all that. And many states are now opening up to new groups, and the CDC is open up to new groups. So did we get that wrong? Were we trying to be a little bit too precise? What's your sense of sort of the who goes first question, and how we've done, and what you think it should be today?
Yeah, I think this is hard. I mean, this is like the Sophie's choice, right? I mean, you want to vaccinate people who are at highest risk. You want to vaccinate people who help the society move along. It's like the Titanic analogy, where you have, so I made a Sophie's choice and a Titanic analogy, but the Titanic analogy is, you only have so many lifeboats. And there, I mean, of the 100 or 150,000 or 200,000 people that are going to die over the next couple of months, would their lives have been saved by a vaccine? Likely. Very likely, yet they didn't get it. It's really hard. You only have so many lifeboats there that enable you to save people, and it just breaks your heart. So get it out there, get the vaccine out there as much as you can. Realize that you're going to be really upsetting one group or another. I got a call from a governor saying, look, here's my prioritization scheme. What do you think of that? And my thinking is like, you're going to anger people anyway. So just do what you think works best.
And what we've seen now is essentially, maybe in part because of the lack of national leadership, 50 different experiments, every state doing it their own way. Are there any lessons to be learned from what you've seen so far? Are any states doing this great, or any states doing particularly poorly that they need to get better fast?
Yeah, certainly. I mean, we don't have the infrastructure to give mass vaccination, and so states will learn at different levels. I mean, states are all different, and so they will learn differently. They'll administer it differently. And I think the 2 or 3 years, we're going to look back on this and figure out what we should have done differently. And hopefully, we'll have things in place so the next time there's a pandemic, knowing there's been 3 in the last 20 years, that we'll be much better prepared.
Now, I know you're going to have to go in a little bit before Charles speaks, but let's talk about the variants for a second.
Yeah, I was hoping to hear him speak, actually. What I want to hear, maybe, can I ask him a question before is he there?
Charles, are you on? If you're causing us to do improv, which we do very badly, but let's see if Charles.
Can I ask Charles one question?
Of course. There you go.
Charles. Okay, there's the Golden Gate.
Yes, I'm on. Hi.
We are so nimble here. Look at that.
Well, here's my question. So I saw with the UK variant, the B117 variant, that there are polyclonal antiserum generated by natural infection, as well as polyclonal antiserum generated by vaccination. Specifically, Phil Dormitzer is making a comment about vaccination with the Pfizer's vaccine that neutralize that virus. It's good. Okay. Do we have the same kind of data for either the South African strain or the Brazilian variant?
So the answer is that I don't believe, I haven't seen data yet about the efficacy of polyclonal sera against the South African variant. And in fact, I was planning to focus on that shortly. But I think the worry is that the South African variant is clearly of more concern than the UK variant with respect to potential vaccine evasion, because of there's some additional spike mutations, most notably the E384K mutation, which has been linked to at least to evasion of neutralizing antibodies to the spike protein. So I'm more worried about
monoclonal or polyclonal.
Monoclonal.
Yeah,
but it also has been reported that convalescent plasma has less activity, which presumably contains polyclonal antibodies, has less activity specifically against the variants which include this E484K mutation, which is found in the South African variant. But so far, all of the data so far supports the idea that the vaccine should be effective against the UK variant.
Yeah, that I saw. And you want to make a prediction, because I guess with regard to the SA variant, or the South African variant, it's really how many epitopes you start to affect before you get a critical decrease, before you cross that line where polyclonal antiserum is no longer effective. And I don't know the answer to that question. I know this virus generally mutates slowly, which is to some extent reassuring, but what do you think?
Yeah, so what I believe is that we've already seen that there's a tremendous amount of individual variability. If I had to make a prediction, I would predict that the infection with the South African variant, probably that the vaccine, it does have perhaps a slight or at most maybe a moderate impact, but it's going to vary from individual to individual. So for instance, some individuals who are vaccinated and maybe if they're infected, if they happen to be infected with the South African vaccine, it may not be, they may generate antibodies that are effective against the South African variant, whereas others, for some reason, with different polyclonal sera would have less activity or slightly less activity. It's my hope, though, that the effect is going to be minimal or slight, but we still have to see.
Thank
And
you.
just for those of us who are not super specialists in the area, Paul, the kind of questions you're asking about, is it the monoclonal antibody, the polyclonal antibody? Why is that an important thing to know in terms of predicting whether the vaccine's still going to work?
Well, the polyclonal sera is really the more important question. I mean, you want to make sure that people who've been naturally infected or immunized are going to be protected against this variant strain. And the only way to know that is to look to see whether their polyclonal antibodies do that. I mean, the monoclonal antibodies help us dissect what specific epitopes are involved. But the important question is, has it escaped recognition by a polyclonal immune response, which is the immune response we make? And it bugs me a little bit, Charles, that we certainly in the United States, we can certainly build up our sequencing much better than we have. And when we identify these variants, we should be able to identify really within a week whether or not they've escaped recognition by polyclonal sera. And it seems it's been a little slow and frustrating.
Yeah, that's a great point you make. I really think that part of the reason is that we do not have, unlike the UK, we do not have a nationwide coordinated network to actually do this type of genomic surveillance, what we call sequencing, to be able to rapidly identify these variants. And I view it as simply flying with a blindfold on, that we simply, if you don't know about the existence of the variants, you don't know what is circulating, what is predominant in your community, there's no way to develop countermeasures or to understand exactly what impact it will have on both our vaccines and the drugs that we're using to treat the infection.
So let me turn back to you. I'm sorry, go ahead, Paul.
No, it was completely selfish on my part. I saw that Charles was there. I knew he was going to be talking about this, and I knew I was going to have to miss it. So
That's great. Thank you. So Charles, let's have you go away for a sec. I'm going to finish up with Paul, and we'll come back to you in probably 6 minutes. So let's maybe one more question to you, Paul, on the variants. Now that we know they're out there, and we'll hear from Charles in a second about more specifics about them, but we know that at least for one, it's more infectious. And we know for a second that it might be at least partly resistant to the vaccine. How does that change your thinking about the vaccine rollout, the importance of speed? Are we gonna have to retool the vaccines over time as the bug gets smarter? So how are you thinking about, now that we know about these variants that actually have changed behavior, how does that change the whole world of vaccines?
Right. So I mean, these are single-stranded RNA viruses, and so they will mutate and they will create variants. So the question is, if there's going to be like flu, which mutates so much from one year to the next that you have to get a yearly vaccine, or is it going to be like measles, which is also a single-stranded RNA virus? It also mutates, it also creates variants, but we've had a vaccine since 1963 and the virus hasn't escaped it. Which of the two is this going to be like? And it'd probably be somewhere in between, but I think that would be terrible news. I mean, if we really generated variants in this world that escaped recognition by the polyclonal antisera that we generate after natural infection or immunization, that's a problem. And then we have to imagine how hard it is just getting this vaccine out there. And we would have to, presumably there would be a multivalent vaccine, if you will. I mean, that you would have not just the RNA that codes for the spike protein of this non-variant strain, but the RNA also decoded for these others. I think it would be a kind of a multivalent vaccine, if you will. But it's hard. You have to get that out there again, and that would really be a problem. That would make me much less optimistic about how quickly.
I mean, does that create a even greater incentive to speed? Like, if we get to herd immunity before that moment, are we protected, or is there now a possibility that this new variant sort of enters our universe and creates 2020 all over again?
Well, again, it's an international community, so whatever goes on in the rest of the world. Also, so that's another argument for arguing for giving that second dose sort of earlier. I mean, there's a paper that just came out in Science yesterday. I don't know if you saw it, that delaying that second dose has caused some virologists to worry more likely to create these escape mutants than if you try and kill it dead as quickly as possible. So we'll see.
A couple of quick last questions. Do we know any more about pregnancy?
Yeah, no, I'm negative. No, I was kidding. I think no, I mean, you had 23 cases in the Pfizer trial of people that were pregnant. You had 13 cases in the Moderna trial. You know, the V-Safe system at the CDC is going to be following these people who get vaccines when they're pregnant. It's odd. Typically, when the CDC makes a recommendation about pregnancy, absent data, they'll always say it's contraindicated. Now, because you know that a woman who's pregnant, who's infected with SARS-CoV-2 is at greater risk of more severe disease than a woman who's of similar age that's not pregnant, you know that. There's no good reason to believe. There was certainly a preclinical study in experimental animals showing that there was no effect on either the pregnant animal or the unborn little animal. So that's good. And so they said that a woman essentially may reasonably choose to get this vaccine. Interestingly, there were 2 cases of spontaneous abortion, one in the Pfizer trial, the other in the Moderna trial, both in women who were pregnant, both in the placebo group. Interestingly.
Interesting. Okay, I think I'm having trouble with my connection, but we will try to go on. Maybe last question for you. We're starting to hear about cases of people who got vaccinated and got infected. Any of them worrisome yet, or it's just all the statistics that even if it's 95% effective, somebody will actually get an infection after even being fully vaccinated?
1 in 20 people. So it's not surprising, I guess, that you hear it. I still think, well, we'll see. We'll see how this plays out. But so far, I mean, it looks like natural infection protects against disease associated with re-exposure. That's good. That means you can make a vaccine. You just have to mimic the immune response from natural infection. I think we've done that with these mRNA vaccines. I'm optimistic that we'll get on top of this as long as variants don't evade recognition by the vaccine. That would be a problem.
Yeah. All right, great. And just for us to calibrate, you mentioned the Eagles, but are you an optimistic kind of guy, or is that your nature?
I think any scientist is optimistic. I really think that. I think as scientists, we generally go from one failed experiment to the next with unabashed enthusiasm. That's what makes of us.
Good. Well, I hope you're right, and thank you for helping us understand this all a lot better. It's really complicated, but and I think the point you make is really important. It's easy to sort of look at the short-term speed bumps that we're seeing and forget that it's a miracle that we find ourselves in January with 2 extraordinarily effective, safe vaccines to give out. So we should make sure we keep our eye on that ball.
Okay.
All right. Thanks much.
Take care. My pleasure. Stay safe.
We'll be talking again in a couple of days. So in other fora, but appreciate it. Good talking to you. All right, let's bring on Charles. Thanks. So Charles, let's bring you out. And I'm actually gonna try to move and see if I can improve my connection. But why don't you go ahead and get started with
absolutely. So I'd just like to start out by thanking Dr. Wachter and UCSF for inviting me to speak with all of you today. I'm going to talk today about the implications of some of the new variants that have been circulating around the world and perhaps even the United States. I think with the first slide, so next slide, please. So with the first slide, I just want to simply point out in this very simple graph, the concept of viral evolutionary rates. So COVID-19, SARS coronavirus 2 is an RNA virus. And so like all RNA viruses, it will mutate over time. One thing though that is perhaps specific to coronaviruses is that coronaviruses, they actually encode for a protein that actually corrects. It's called an error correcting protein that actually corrects for the sequence, the viral sequence, that corrects for mutations that occur in the viral genome or errors that occur in the viral genome. And as a result, it tends to mutate much more slowly than other RNA viruses. For instance, it's about 2 to 6 times more slowly in terms of mutation than influenza. That being said, we do know that it will mutate. Next slide, please. And indeed, one of the significant mutations that arose, and this began in perhaps from very early stages of the pandemic in March, was the emergence of a variant that we call the D614G spike protein variant. This is a specific mutation at position 614 in the spike protein. And you can see here that this variant has rapidly emerged over time, and now it's roughly thought to be about more than 99% of all circulating viruses currently. Next slide. And indeed, one of the reasons why it's been postulated to have spread so quickly is that it has been shown to increase infectivity in cell culture and animal models. So this is how we typically investigate as virologists, how we typically investigate how, how the infectivity or how rapidly transmitted these variants could be. These are studies, and I just put down, there actually have been several studies. I just give you reference to two of them below here in this slide, where you can see that this variant, which is shown in red, which is the G614, it's a D to G amino acid change. You can see that this particular variant does grow better in cell culture, as you can see on the left. In addition to that, it also replicates better in a mouse model of COVID-19. Next slide. But in the meantime, this virus is continuing to mutate. And as you can see here, what we're worried about now is that we are now, there have been reported variants which have additional spike protein mutations. So what I show you here, this is a medRxiv preprint, which shows you the crystal structure of the virus spike protein, or actually, in this case, it might be the cryo-electron microscopy structure of the complex of the spike protein with its receptor, which is human ACE2 receptor. And I want to point out the existence of several additions, mutations that have been found circulating in various viruses currently both in the US and globally. So there is a mutation called the N501Y mutation. And this mutation is particularly concerning because it's a mutation directly within the receptor binding site. It's the part of the spike protein that directly binds the binding site to the human ACE2 receptor. So you might expect, and understandably, one thing that can occur with mutations in the receptor binding site is that these mutations will enable the virus to enter cells more readily, and in fact, essentially make the virus more infectious, resulting in perhaps a greater transmissibility or greater infectiousness. Similarly, there have been other types of mutations, and I'll point out, really highlight two of them. One is what we call a 6970 deletion mutation. So this is a different type of mutation where it's not a change in the nucleotide or the amino acid that makes up the protein. It's a deletion. It's where you actually lose a nucleotide or a series of nucleotides or amino acids within the sequence. And the reason I'm pointing out the 6970 deletion mutation is not because it has a functional impact, even though it may potentially have a functional impact, but it has been useful for us with respect to being able to identify these mutations, because what happens is this particular mutation makes the tests that we use for diagnosing coronavirus negative, at least for tests that target this particular gene, the spike protein or the spike gene of the coronavirus. And then the last mutation I'll be talking about is the E484K mutation. This is another mutation which is which can occur in the spike protein, and it's of great interest because this mutation has been shown to have some relevance to the ability of antibodies to neutralize the virus. And so the worrisome nature about mutations at this particular site, 484, is that these mutations may potentially enable the virus to evade vaccines or monoclonal antibody therapies. So a mutation that potentially may make the vaccine less effective. And I'll be talking today about two specific variants. One is the UK variant, which is otherwise known as B117. This variant contains the N501Y mutation and the 6970 deletion mutation, in addition to the D614G that we just went over. Notably, both of these variants, they still have the D614G backbone as part of the backbone, in that more than 99% of all circulating viruses have D614G. The South African variant has additional mutations in the spike protein, and the one I'm going to focus on today is the E484K. Next slide. So this is the worry about the emergence of this highly transmissible UK variant, B117. It was initially described actually in the United Kingdom in early September. Since then has spread to multiple countries, actually more than 31 countries, including the United States. And this is data as of yesterday. And you can also see that there is, or as of last week, you can also see that the variant has rapidly increase in its proportion in terms of the number of cases in the United Kingdom. Currently, it began in early November. It was only 5 to 10% of cases, where now it's really is a majority of cases. More than 60% of cases, and perhaps even more, are now this B.1.1.7 variant. And the other point I want to make about this is that this is a variant that has a rather unusual number of mutations. I did say that this is coronaviruses do mutate, including this one, and yet the rate of mutation is typically thought to be relatively gradual and slow. In general, we see perhaps 1 to 2 mutations a month. You can see, and on average, if you look at the current circulating viruses, on average, they typically have anywhere from, say, 8 to 11 different mutations. This is a rather unusual variant in that it suddenly occurred in England in September, and it had 23 mutations. And I'll talk about the significance of that in the next slide. And next slide, please. So this is kind of an interesting question, is how exactly did this variant come to be? If you can, this is basically a kind of a genetic divergence map. And the general idea is what we want to do is we want to see, as mutations begin to accumulate, we want to track to see how the dates of collection, and we want to see how these mutations are evolving. And you can see in general, if you look at the line, kind of the lower line, this is a regression line, which basically suggests, and this is the case for the vast majority of the strains that have been circulating, is that there's a gradual increase in the number of mutated viruses, or in the evolutionary rate of mutations. If you look at this particular lineage, though, it appears to be almost like an outlier. It's basically way above there. It's as if it suddenly jumped from having, say, 8 to 10 mutations on average to 23 mutations. So how can this actually occur? And how did it occur? Well, there have been several hypotheses. We don't have the answer yet. One idea is potentially there may have been mutations and evolution of the virus within a certain individual. This is what we call quasi-species evolution. The idea is that an individual may be chronically infected with the virus and may be unable to fully clear the virus. So this may be the case, for instance, for immunocompromised individuals, patients who have undergone, for instance, a bone marrow transplant. Now, we don't know yet whether or not this is really the case, but we do know that patients who are chronically infected with SARS coronavirus 2, they can develop many mutations, say anywhere from 5 to 10 additional mutations during the course of their infection, simply because they have a prolonged infection or prolonged infectious course. Another possibility, which has also been hypothesized, is that perhaps this lineage arose because there was separate evolution in perhaps an animal reservoir. There have been some instances of, for instance, human to animal and animal to human transmission of coronaviruses. And so the idea is there have been, for instance, outbreaks of this particular virus in mink farms in the UK and in other countries in Europe. And the idea is that potentially did this strain or variant arise within evolution, say within a mink, and then jump back from the mink to a human. So we don't know the answer yet, but we do know that there are plausible mechanisms for how these variants can emerge. Next slide. So how do we actually test for the variants? And as I said before, what was quite fortunate is that this particular variant, the UK variant, it has a 6970 deletion. And the idea behind it is that when we do testing for the virus, we often, the common tests that are being used, they often target more than one gene. So for instance, very commonly tests will, there may be a test that tests for the S gene or the spike gene, and simultaneously tests for the N gene or nuclear protein gene. And typically you need to be positive in kind of either one, or in some cases, both of those genes for you to call the test positive. Well, what has been noted is that there's this phenomenon called S gene dropout. And what that means is that you have a test that's positive for one of the genes of the coronavirus, say the N gene, it's not positive for the S gene. And what that indicates is that you are still infected with the virus, but you were infected with a variant that causes this S gene dropout. And it just happened, fortunately, that this deletion, the 6970 deletion that's found in the UK variant, has this phenomenon that it causes an S gene dropout in our testing. And as you can see here, this gives you, this is basically the idea, some laboratory data which shows that there's a frequency of S gene dropout viruses in the tested US population. And you can see here that what's interesting is that we started to see S gene dropouts sort of in November, around the time that we saw the emergence of these variants, such as the UK variant. And now one screening method that we're using for identifying these variants, at least the UK variant in the US, is by looking at all of the positive COVID cases which have S gene dropout on their testing. Next slide. So by doing this type of screening, you can see that to date that we've identified about, as a nation, about 76 total cases of the UK variant. Understandably, many of them have identified in states that already have active sequencing centers that are doing kind of active genomic surveillance. And in fact, the state where the most cases have been identified, primarily from San Diego, was in California, with 32 cases so far. Next slide. So this gives you an idea of the spectrum of kind of how we're identifying these variants. And what I show you here in red are actually two variants that my laboratory identified from San Bernardino County, cases of these variants. So this was the B117 or the UK lineage. What's important to realize though is just because you have this S gene dropout doesn't mean that you're infected with the UK variant. You may in fact be infected with a different variant that also has the same deletion, like B1315. So that was indeed the case. We ended up screening, 3 patients who had S gene dropout, and 2 of them were found to be infected with the UK lineage. Next slide. So I want to talk about the significance, given that the focus has been on vaccines. Well, one thing, it has been found that, and this is very reassuring data, that sera or polyclonal sera, which is sera containing polyclonal antibodies from individuals who have been vaccinated, have been found to neutralize effectively the B117 UK variant, which is really good news with respect to vaccines. It's likely that vaccines will be protective against this variant. Next slide. I want to move into the South African variant, but before I'll probably end by saying that there is additional data which really suggests that the UK variant, although it may not hopefully impact the efficacy of the vaccine, this is a variant that, similar to D614G, has been shown to be more transmissible, as you can see from the experience in the United Kingdom. So our worry is that if the outbreak is allowed to continue, that there may be a possibility that this variant may eventually expand and grow to predominate the population. And having a more transmissible variant has a lot of implications, because for one idea is that it may overwhelm our healthcare system, given that the sheer number of additional cases and hospitalizations that may result from having a more transmissible variant in circulation. The second thing is that it may also hinder our achievement or achieving herd immunity with the use of mass vaccination, because we will likely, with a more transmissible variant, will likely have to vaccinate even more individuals and even more people for us to be able to successfully achieve herd immunity. I want to end by talking specifically about the South African variant, which is yet another variant which is quite worrisome. This gives you an example of the sheer number of cases that have resulted from the South African variant in South Africa. This is published data. You can see here that the South African variant is primarily responsible for the second wave of infections in South Africa. And you can see it's really going up like a hockey puck. Next slide. So this South African variant has its own pattern of mutations. And I really want you to focus on, these are actually mutations that are just in the spike protein. And you can see here that there are quite a few. I mean, we're talking 8 to 10 mutations in the spike protein, even more than are found in the UK variant. But of particular interest is one mutation, which is this E484K mutation in spike protein. Next slide. So these are also preprints because this data is very recent, but there is a lot of worry about this particular position, this E484K mutation. What you can see on the left, these are neutralizing dilution. So the idea behind this is that the way the experiment is done, that you basically engineer viruses that have this particular mutation, and then you determine, how well, the question is, how infectious is the material after you treat it with presumably neutralizing sera. So this gives you, these are neutralizing sera from convalescent patients. So patients who already have monoclonal antibodies, they've already generated antibodies, they've been infected. So presumably their antibodies should be able to neutralize the virus. And so what you can see here is that the viruses that contain the mutation, they're sort of like the upper kind of yellow curve. You can see those viruses are less able to be neutralized. In other words, they remain infectious even though you treat it with neutralizing antibodies. And what that really suggests is that there's a potential for neutralizing antibodies simply not, at least the ones that are made in response to natural infection, and maybe even those that are induced in response to the vaccine, may not be as effective against viruses that contain this particular mutation. Another way of looking at it was a study that was done on the right, where what these investigators did was they essentially mutated multiple positions throughout the spike protein. And they found at which positions, the question was, at which positions in the spike protein is there a greatest effect on the ability of antibodies to bind to it. And if you look here, when you actually plot that, in what you can see there in the XY plot there, you can see that 484 is really high. Is almost like it happens to be a very significant position. And what that means is mutations at 484 are likely have the greatest amount of effect or impact on the ability of antibodies to neutralize the virus, at least at that position. Next slide. And another way to look at this is actually to see, how does the mutation actually affect antibody neutralization? So this is a really these are really interesting studies where what you see in panel A is, this is basically neutralizing activity this is all convalescent sera from different patients. And you can see here that based on neutralizing activity, that as you go from wild type virus to a virus that has the D614G mutation, the second row, to a virus that now has this E484K mutation, you can see that the neutralizing activity gets weaker and weaker. In other words, sera is convalescent sera that contain polyclonal antibodies are less effective against these viruses as they develop these significant key mutations. Another way of looking at it is the bottom panel, where they tested a variety of monoclonal antibodies against the spike protein. And similarly, you can see here that as you go from a wild type virus to a virus that has more of these significant mutations, you can see again that the activity of the ability of those viruses of antibodies to neutralize the viruses decreases. And this is why, and this is data which is in the laboratory. Now, we still haven't directly shown that the South African variant or infection by the variant, or the potential infection of the variant, makes vaccines less effective, or the vaccine is less protective against these variants. Although this in vitro data, laboratory data, is quite worrisome for the possibility. Next slide. So I just want to end with kind of three key messages, and this is really a tale of three variants. So the first message is that there is a predominant circulating lineage. It's a D614G spike mutation, and in fact, all of the variants that we're talking about, they all have D614G. It has been more than 99% of the sequence viruses as of January 2021. There is a circulating UK variant, which is now known to be in the United States. It has 23 mutations, so it had lots of mutations. It does appear to be more transmissible, both by epidemiology and in the community, as well as in the laboratory. There's no evidence so far of any impact on vaccine effectiveness, which is good news. And it may possibly have originated from chronically infected individual and animal reservoir. Regardless, it did originate. And so what this suggests is that there is a potential of additional variants that have these types of mutations in the future. And the last point I want to make is that there is also another variant variant, the South African variant, which arose independently of the UK variant. It has not been found in the United States yet, but now it is in 11 countries outside of South Africa. It has even more mutations in the spike protein, and as a result, including the key E484K mutation, these mutations may allow this particular variant to evade antibody-mediated immunity. And so I think the take-home message is that we're really in a race now, and really this only increases our urgency to mass vaccinate the population and protect the population before additional variants may evolve and emerge. So I'll end there, and I'll be happy to take any questions.
Great, thank you, Charles. I'm hoping my internet will hold out. Let's take 5 minutes for a few questions. What we saw in the UK was that variant quickly became the dominant strain. Now that we know it's in the US, and I assume far more widespread than we know about because we're flying blind, is there any reason to believe that it won't become our dominant strain? And we know that it's 50% more infectious. So is that sort of an inevitable thing that it will become the dominant strain if it's the faster runner?
We don't know yet, and I think for a couple of reasons. One is that it does have the D614G mutation, which does make it more transmissible already at baseline. But in addition to that, pretty much every strain that's circulating has D614G. So the question is, how much more infectious is it than the currently circulating strain? So that's one big question. The second reason why I'm not sure. So there may be a very small difference in terms of the absolute difference in infectivity between the UK variant and other variants that are currently circulating. The second reason is that currently it appears to be at a very low fraction of the cases that we and others are sequencing, probably less than 0.5%. And the idea is that it may never go beyond a critical threshold where you start to see exponential growth, especially as we continue to increase our vaccine efforts and as we continue to hopefully follow kind of social distancing and mask wearing and other public health guidelines. There is certainly a possibility that we may keep this variant at bay. So it's not inevitable now that we have kind of currently, at least as of now, have a low prevalence. It's not inevitable that we're going to see kind of it become the predominant strain.
I hope you're right. In terms of the South African variant, if it does have these mutations that allow it to partially dodge vaccination, does that imply anything about infectivity? And if it doesn't, and it's as infectious, why would it become a dominant strain, or would it be inevitably consigned to become be a fairly small part of the viruses that we're dealing with?
Yeah, the evasion of vaccine immunity, as I said, it's probably the E484K, and there may be another mutation that we didn't talk about in the spike protein that may reflect its perhaps the potential to evade immunity. That does appear, though, to be different than other mutations in the spike that may affect infectivity. So one thing of note is that the South African variant has the same N501Y mutation that appears to be in the UK variant as well, and that may be the key mutation that affects infectivity. So and based on the experience of the cases in South Africa and the explosion of cases there, I would suspect that probably it is also more infectious and more transmissible. I think what the worrisome aspect of it is that it has these additional mutations that may confer resistance to or partial resistance to vaccines. I want to make it clear, though, that we haven't proven that has not been proven yet. It's really been laboratory data that's been suggestive, but what really needs to be done is direct data that basically answers the question of, does it really affect the efficacy of vaccines? As we commented on before, because the vaccine, the polyclonal antibodies that are made by individuals in response to vaccination can vary significantly, I anticipate that if it does have an effect, it's not going to be a uniform effect. It may be, there may be a slight decrease in efficacy for some individuals and not for others, for instance. And certainly because vaccination induces antibodies pretty much against the entire genome, against multiple sites throughout the genome, it's more likely that if we do see an effect, it's hopefully going to be a very slight difference and not, say, a significant difference that may, for instance, require a new vaccine. It's my hope that the vaccine will retain, to a larger part, quite a bit of efficacy.
Let's hope so. The last question is, now that you know that these variants have entered our world, at least the UK variant and maybe at some point the South African variant, what's your recommendation to people about their behavior? Should they keep doing what they've been doing? Should they just be sure that they do it more religiously in terms of masking and distancing? Or should they even become more rigorous? If you wore one mask, you should wear two. If you were keeping 6 feet apart, you should go 9 feet apart. How do you think about that?
Yeah, the way I think about it is that although these variants may be considered to be more infectious, or the evidence suggests that, I mean, the virus at baseline is already very infectious. We already know that. And I don't think that the existence of these variants should really change anyone's behavior, in the sense we still have to adopt the common sense public health measures, guidelines for preventing infection, which include mask wearing, which include social distancing, includes avoiding large gatherings. I mean, the same measures that we're currently doing to help prevent spread are going to be effective against these variants. But I do think that what it does from a public health standpoint, it really increases the urgency of really making sure that people get vaccinated as soon as possible. So the other thing that I would highly recommend is that if you are eligible to receive a vaccine, that you should get vaccinated. It's not only good for you yourself in terms of being protective, but potentially it would be good for public health as a whole.
Great. Thank you so much, Charles. Really appreciate it. It's complicated and important. And thank you for sort of the slightly optimistic spin on it. Obviously, there's plenty more to learn, but we've got to, it's not as if all is lost from what we've heard. So let me close out. First thing, to invite folks to attend the first of a new series that we're starting today in the department from 5:30 to 6:30 on anti-racism. I will send out an email to everybody in the department in about 10 minutes. Let me thank my crack production team. They are listed there. Next week, we'll go back to a non-COVID topic, and this will be on the use of social media in medicine, hosted by our Chief Resident, Anjali Thakar and Eric Wadera. And I will be on as a guest. Kirsten Bims-Domingo and Vinny Aurora from the University of Chicago will join us. We'll be back for another COVID grand rounds in about 2 weeks, actually in exactly 2 weeks. And so until then, please stay safe, and we'll see you soon.